So we're going to get started with this morning's breakout session. Two amazing, awesome speakers that we're so lucky to have here today, both of who I've learned a lot about healthcare in my job through their work. So I'm glad you're all going to get to see them here today as well. We're going to start with Lorian Hardcastle, who is going to be doing what's it called? Building a Sustainable Healthcare System for Alberta. So Lorian Hardcastle, she's an associate professor in the Faculty of Law and Cummings School of Medicine at the U of C in Calgary. She has a JD with Health Law and Policy Specialization from Dalhousie University, a master's and a doctorate in law from the University of Toronto. She's completed a bunch of fellowships. You'll see that in your booklet. Her full bio is there. She writes extensively on health law, on policy, and she's in the media all the time talking about those issues, often in the same news stories with me. I'm like, oh, what did she say? Great, I'll say that too. So I'm so glad that she's here today to present to us. So I'll let you get started, and onwards we go.
And so what I wanted to do was to talk about some of the changes that have already happened, some under Premier Kenney, some more recent, and then a little bit about where we're going and some of the concerns with what we've seen and where we're going. And hopefully within those concerns, particularly the forthcoming ones, there's opportunity for advocacy and trying to influence policy, which I know can sometimes feel like banging your head against a wall in certain jurisdictions. I think we'll start with sort of the obvious change. One of the directions that we've seen this healthcare system go in, really starting with Premier Kenney, but carrying on with Premier Smith, has been an increasing embrace of corporatization, privatization. I think we can expect that to continue. With respect to privatization, the government thus far has focused primarily on contracting out. So you'll see them over and over again say, we're not making you pay, you're not going to pay, there's nothing to see here, nothing to worry about. And so the focus has been on that private delivery, primarily of surgeries, rather than private finance. This is the one of the latest private surgical facilities that's going up. The other movement that we've seen is towards corporatization, and I think that the birth of virtual care is really the best example of this, where we saw TELUS and PC stake out a pretty significant part in the healthcare system by being the ones to administer the delivery of those virtual walk-in clinics. I think we're likely to continue to see this, and the government actually changed its legislation a couple years ago now to facilitate more corporate middlemen in the health sector. And the specific legal change they made was historically only physicians or physicians via their professional corporations could bill the government for providing insured services. But we had legislation, what feels like a lifetime ago, but was only a couple years ago, that allows for other entities to also be the ones billing. So they can kind of act as that middleman between the government, and then they can be the ones to contract with physicians. So I think we're likely to see more of that corporatization. And then most recently, some of you may have been following the news in Calgary. There was a primary care clinic there that wanted to charge a yearly fee for patients to access those services. It's not new. This has been done sort of in a fancier executive way for years, but we're starting to see it more at that basic primary care level. And the issue there is that sometimes the reason they've been allowed to kind of stick around and skirt the law is because they would say, well, we're charging people for uninsured services, not insured services. But the issue with these clinics is that they kind of mix the two together. So they're commingling the uninsured and the insured, and what's happening is people who are paying these fees are not just paying for uninsured services, which is allowed under the law, but they're also sometimes getting that faster access to insured services, which raises those kinds of equity issues. Health Canada has shown some interest in cracking down on some of this. Last year, they cracked down on some of the private diagnostic clinics. They've indicated that they're coming next for virtual care. In Alberta, we do still have, of course, publicly funded TELUS, other virtual care, but in some provinces, those billing codes have been dialed back, and people are really paying quite a bit out of pocket for that virtual care, and so apparently Health Canada is coming for them. We'll see what that looks like in terms of the actual dollar values withheld. But that's some of the general kind of privatization, corporatization. This is a direction we're going to continue to see the system move in. In terms of the concerns, the government would have you believe there are no concerns, right? It's fine. You know, we're the ones paying for the surgeries that you get at these private facilities. You're not paying. No big deal. Don't worry about it. But there are concerns, of course. There are concerns with quality. We know from the for-profit long-term care context that there can be quality of care issues associated with for-profit delivery. For example, we might see quality decline when corners are cut, like staffing, in order to eke out that profit from what they're being paid. And then, of course, in the US, there's a plethora of different contexts where that for-profit status and quality has been studied. And so there are those quality concerns with these facilities. And we haven't heard a lot from government on how it's going to work with the colleges to regulate quality in these facilities. There's, of course, the cost issue. These facilities, the chartered surgical facilities, for example, tend to take the cheaper, easier cases. Makes sense. Those are more efficient for them to perform, but also there are some people who just can't safely get surgical services in a chartered facility. They really do need to be in a public hospital. And the concern is that if they're getting paid kind of the average rate to do a particular surgery, but they're doing the cheap, easy ones, then that will cause the costs to creep up over time. And so those are two issues that I think we could probably do more to push back on the government about. I had the pleasure of doing Danielle Smith's radio show a couple times before she was premier, and that was what I said to her listeners. I said, you know, I'm sure you're an audience that thinks that private delivery is more efficient than public hospitals, and I'm not going to change your mind on that, but you should care about quality remaining high. You should care about costs not going up, and you need to hold the government's feet to the fire to ask them how they're doing those things. And we don't have a lot of information on that. And then, of course, the final big issue with this shift, particularly towards these private facilities, is the equitable access piece. As I mentioned, these facilities tend to take the cheaper, easier cases, and if these facilities are taking those cases and are pulling health professionals away from public hospitals, they're competing for the same pool of health professionals, then what you can end up happening is those less sick people with the easy cases will sometimes get treatment faster than those who have more complex medical needs and are waiting for care in public hospitals. I think we'll hear more from Rebecca on this, so I'll leave it at that and move on to some of the other changes. This slide is new. This slide was not in this when I wrote the abstract, because as we know, this was all sprung on us about a week and a half ago, 2 weeks ago. Another big change in terms of governance of healthcare in Alberta that's coming is this reorganization of AHS and the healthcare delivery system more generally. This reorganization, I haven't seen or heard of any evidence from it. The government's been asked, you know, what system is this based on? Where are you getting these ideas from? Where's the evidence? And they haven't produced an answer, and I don't think they have one. I think that we see healthcare systems around the world going in the opposite direction, more integration, better coordination, and this is really the opposite. We're moving towards fragmentation. And I think a lot of this is ideological. We saw that AHS was a scapegoat for the government during the pandemic. We sort of heard the government expecting AHS to continually find more beds out of nowhere. like more beds. They're not finding enough beds. Meanwhile, as you all know, after the kind of open for summer debacle, the problem was that the government wasn't dealing with the other side of that equation, right? More beds, more beds, more beds. Okay, but what are you doing as the government to prevent people from needing those beds? It's two sides of the equation. And so what we saw in Premier Smith's leadership campaign and then the election was a real scapegoating of AHS, that they were the problem, they were the reason that we had to have public health restrictions, they have too many managers. And so what we're seeing now is this breaking up of AHS that was announced about a week and a half ago, I think. Time sort of stands still when you wake up every day and there's weird health policy announcements in Alberta, but I think it was about a week and a half ago. And so what's happening now is AHS, which of course has a very significant role in the delivery of acute care services, other healthcare services. They have policy-making functions. They're going to sort of shrink down into just one bullet under that acute care box. They're going to continue to deliver acute care services along with Covenant and the chartered surgical facilities. And at the press conference, they were almost just placed on equal footing with those other entities. And we're going to have these 4 new organizations in the healthcare system, each with their own area of delivery. 3 of them, acute, primary, and continuing care, are going to report to the Ministry of Health. And then the 4th is going to report to some combination of the Ministry of Health and the Ministry of Mental Health and Addictions. There's also going to be an integration council that somehow coordinates all of this. There's going to be 12 local advisory councils, an Indigenous advisory council, a procurement secretariat in the government. Remember, the Premier said that she was concerned there were too many managers in AHS. I fail to see how this won't have more managers, bureaucrats, etc. And prior to all of this, Alberta did have some of the lowest administrative costs in the country. I don't see how this reorganization is going to save administrative costs. And the government has not been transparent about what all of this will cost. There were some leaked slides that had numbers, but when the government was actually asked at the announcement, they weren't really able to cite any specific numbers. They kind of referred to, well, in 2008, we spent this much on a reform, so kind of with inflation, maybe like that, but no specific numbers. I think another problem with all of this is as I mentioned, most healthcare systems are moving towards more integration. There are several provinces right now that are moving to a system like Alberta's with something like AHS. So other people are seeing the value in this kind of system, and we're moving away from that. And I think there's a real risk of patients falling through the cracks. If you have someone who's moving from primary care into acute care and then out to continuing care, and those are all being overseen by completely different entities, there's this worry that people will fall through the cracks. There's also a concern with who does what, right? So if you have something like inpatient mental health services, is that the acute care entity that's doing that, or is that the mental health entity that's doing that? How are they working together with one another? And I think all of this, not only am I concerned about the lack of evidence for all of this, but the instability it's going to bring to the system at a time when the last thing we need is instability. I mean, this is all very chaotic. Instead of targeting the specific issues that needed targeting, instead what we're seeing is, well, let's just make a whole bunch of changes and almost just change for the sake of change. Let's just, we want to be made to be seen like we're doing something. Look at how big this thing we're doing is, instead of more narrowly targeting the issues at hand. I think if I had to sort of pick what's good about this, maybe, one thing I think is maybe positive is having a dedicated entity to primary care. I do think that's an area where we probably do need more coordination and more of a working relationship with acute care and primary care. So, if I had to sort of, you sort of like make little kids say something good, like what's the good part about your day and the bad part about your day? The good part about this is maybe an entity devoted to primary care. As many of you know, one of the biggest problems we have in this province is retention and recruitment of healthcare workers. And the concern that I have is that this is not going to help with that. If you're looking at your residency options as a new physician and you see this, or you see what BC's doing or what Ontario's doing, and not without their problems, but at least there's some certainty. I think that this model will make it difficult to recruit healthcare workers because they're coming to who knows what. They're coming to potentially organizational disarray. They're coming to having to spend more time learning new systems rather than on patient care. And they're also coming to a system where there are concerns that it's more about the ideology than the science. So I think that this is not going to help with what is arguably our number one concern right now. The other big change that we're seeing, again, over the last couple of weeks, things are moving really quickly, are changes to public health governance. We know during COVID that there was often a lack of clarity about who was making decisions, on what basis they were making decisions. I think the government had a bit of a have your cake and eat it too approach, where when things were going well, the cabinet and the premier and the minister of health were very much responsible for, as they would say, successfully balancing lives and livelihoods. But then when things were going badly, they would say, well, we followed the advice of Dr. Hinshaw. We were just listening to her. And so there was a lot of lack of clarity. There was perfect clarity in the law that Dr. Hinshaw was the decision maker, but there was a lack of clarity in reality. And there was this real mismatch between the law and what was actually being done. Many of you will know that as a result of the government not following the law, and they could have changed it. They had chances to change it. But as a result of the government not following the law during COVID, a bunch of people were acquitted of charges under the Public Health Act. This is sort of the scene in front of Grace Life Church when they were trying to shut it down. The charges against that pastor, the charges against the Whistle Stop Cafe owner, who was also a famous opponent of the COVID public health restrictions, those were all dropped. And so the government has now introduced Bill 6. Bill 6 adds clarity. It maybe isn't the clarity you want. It's not, authority remains in the hands of the Chief Medical Officer of Health. We're going to have that person be the primary decision maker during COVID. It clarifies that Cabinet is the decision maker. So Cabinet will be the one to make those decisions during COVID or any other future public health emergency. Cabinet will also have the power to override any decisions of medical officers of health, whether during a public health emergency or otherwise. If Cabinet is going to be the decision maker, then what we needed in that legislation that we didn't get is a mechanism to make the Chief Medical Officer of Health's recommendations public. So if Cabinet gets to decide, then the Chief Medical Officer of Health those recommendations have to be public. And for two reasons. One, if you know what the Chief Medical Officer of Health is recommending, you can make decisions that keep your family safe. Right? Even if they're not going to order you to do them, you can still do them. And then secondly, you can then hold Cabinet's feet to the fire if they're not implementing those recommendations. And this isn't an Alberta-specific issue. There was an inquiry into COVID in long-term care in Ontario, whereby the government adopted a threshold for public health measures that was 2.5 times what the Chief Medical Officer of Health recommended. This all came to light. And the inquiry report said the Chief Medical Officer of Health should have not only the independence to report recommendations to the public, but a duty to, so that we know what's being recommended. More recently, mere days ago, the government released a report from Preston Manning that looked into COVID and looked into public health governance. He would have agreed that we should have Cabinet as the decision maker and that there should be a centralization of authority. And the Chief Medical Officer of Health is barely mentioned in his 108-page report. He did recommend greater transparency, which I think is the high point of his report. Who's deciding what? On what basis are they deciding it? But the concern is that his report recommends what I might call a values first, science second approach. So I think in an ideal world, we would say, okay, well, what's the science telling us? And then how can we implement that in a way that's consistent with our values, that reflects the charter? This does the opposite. This says, well, what's the ideology we want to govern public health? And then, we'll look at the science, but we'll also look at alternative views and other approaches other than science. We don't know the extent to which the recommendations in that Manning report are going to be implemented, but there is a concern that with Cabinet now having the power and being the decision maker, if they adopt those report recommendations, their decisions will be more ideological, more less science-based. All of that is sort of already happening, but what's to come? There's a number of things that I think are on the horizon, and in some ways, the government's not going to announce breaking up AHS and then undoing that because we all push back as citizens. That's not happening. These are things, though, that are either have been announced or have been announced in part, or there's some suggestion they're going to happen. And so I think these are areas where there really is room for trying to bring people together and trying to influence the government. So the first is scope of practice changes, and we know that the government plans to allow nurse practitioners to do more. They plan to allow them to direct bill the government. We know that pharmacists already have a broad scope of practice in Alberta relative to other provinces, but that may broaden. We don't know what else is on the horizon. The Manning report recommended a greater role for midwives. It recommended a greater role for LPNs. But I think that we're going to continue to see movements in scope of practice and potentially movement in making it easier for foreign-trained healthcare workers to come into the jurisdiction and work. And so that's an area that I think we'll continue to see. I think we're going to continue to relatedly see changes in the relationship between the government and not just health professionals, but specifically their regulatory colleges. There was a report a few years ago on the Health Professions Act that looked at the government pulling several functions of the colleges into the government itself, and possibly it doing more licensure, it doing more discipline. We also saw Minister Shandro at the time issue directives to the College of Physicians to change their policies around physicians closing practices or moving. So I think we're going to see more government, a centralization of control. We're seeing that with the changes around AHS. We're seeing that with public health. I think we'll also see a centralization of control in that relationship with health professionals. The government calls it compassionate treatment. I have called it compelled treatment. We know that the government here is hostile to harm reduction. They've embraced a recovery-based approach to addictions. And what they've said is on the horizon is legislation that would enable them to compel treatment of individuals experiencing addictions. I'm confident that legislation is coming, probably in the winter or the spring. There are issues with respect to the charter. I think on its face, legislation that forces people to get treatment violates the charter, and if the government is going to violate charter rights, it has to show justification. And I don't think it has justification. They can't point to jurisdictions where this has been successfully implemented. So I think from a rights perspective, that's a huge one to me and one to be concerned about. Private finance, it always kind of lurks in the background. The government has said, we're not making you pay. The Manning report recommends that we do consider private finance, so it's always there. I worry that if we had a conservative federal government, that the door would be open to private finance because a conservative federal government would be willing to open up the Canada Health Act. Because the only thing keeping private finance away right now is the federal transfer payments, is that we keep access without financial barriers in order to get those federal transfer payments under the Canada Health Act. We've heard various conservative politicians over the years talk about potentially opening up the Canada Health Act to innovative delivery models, which we all know what that's code for. So private finance is another one to watch out for. Health spending accounts. The Premier campaigned on health spending accounts. This would be every Albertan gets a few $100s from which to pay for uninsured services. The issue there is equal to give each person the same amount of money, but it's not equitable. I don't need $300 to spend on, I don't know what I would spend it on, a massage in December before it's expired. I have benefits through work. Some people need way more than $300 just to get to March, paying for prescription drugs. So, equal but not equitable. And so that's something that I think we could possibly see in the spring, and there's room to push back on what those accounts include, who's eligible for them. I would rather me get zero and somebody else not get zero, but I don't think that's what the government will do. Maybe I'll leave the last one till last. Conscientious objection, there was a bill that kind of died out, but I think we may see revived based on what the UCP voted on at their annual general meeting. That would allow for not only health professionals to consciously object to healthcare services, but also health facilities. So to object to reproductive care, medical assistance in dying. The government, the UCP at its annual general meeting indicated that it plans to oppose the federal expansion of medical assistance in dying. So there could be a resurgence in conscientious objection arguments. And some provinces have gone the other direction. I think it's Nova Scotia doesn't allow health facilities to object on the conscientious basis. Individual health providers can, but health facilities, they've foreclosed that. And that's actually a whole weird open area of the law that's unresolved in Canadian law is, can a corporation have a conscientious objection? Like, can you have religious beliefs if you're a corporation? That would be taking us in the opposite direction that other provinces have gone in. And then the final change that I think is coming, whether we like it or not, it showed up in the Manning report. It showed up over and over and over again at the UCP annual general meeting, which is more guaranteed rights in the province. We have the charter, it guarantees certain rights, but there's a push to expand an Alberta Bill of Rights to include right to be free from coercive healthcare treatment, inability of entities like the colleges to sanction their members for promoting questionable treatments, obviously outside of my expertise, but parental rights. Whether we like it or not, that's coming. And the Manning report not only proposed expanding those rights, but also making it easier for individuals to challenge government policies in the courts. They want to sort of tinker with exciting pieces of legislation called things like the Judicature Act that would alter those court processes to make it easier for people to challenge those things. And I think the issue with that is that if we have all of these healthcare rights that are enshrined in law, it makes it difficult for the government to pass laws and policies that would do things like protect us in a public health emergency. It would be, depending on the extent to which that's embraced, it would be impossible to bring back vaccine passports. It would be near impossible to close schools for all but the shortest amount of time. Not that we want to bring those things back, but the fact that they would be potentially just off the table is challenging. Just to sum it up, and then I'll turn it over to Rebecca. I think the issue here is that there's a lot of potential changes on the horizon. Everybody needs to try to make their voices known around these, because the specifics of them aren't a done deal, unlike, say, the AHS or the Bill 6, which are going to happen whether we like it or not. There are still specifics to be ironed out here and room to try to influence how they're implemented.
Thanks so much. That is a lot. There's been a lot going on this month. Now we have Rebecca Graff McRae. Her presentation is a series of unfortunate events, lessons from Alberta's healthcare crises. And Rebecca, just for some bio notes, she's completed her undergraduate and doctoral studies at Queen's University Belfast with a PhD in Irish politics, which is fun to chat with her about, but won't be today's presentation. She's interrogated the role of memory and commemoration in post-conflict transition. She's done a great report on labs in Alberta, misdiagnosis, privatization, and disruption in Alberta's medical laboratory services, something I go back to often, as well as a report on healthcare under NDP governments. So she has a lot of knowledge to share with us today, and I'm sure we'll have an equally uplifting presentation about what's happening in healthcare here in Alberta. Thanks, Rebecca.
I feel like Lorian and I should have collaborated a little bit. We could have had a fabulous double act going on here. So you may find that we're overlapping a little bit on content. I'm going to try to give a little bit more of a deep contextual dive on some of those points and how they have become so relevant in the current situation. 2 short notes on my title. The first is that you may find it a little bit of a callback. I took from my inspiration the books by Lemony Snicket, A Series of Unfortunate Events, and anyone who's familiar with the books or the Netflix series may find some little Easter eggs as we go through. It's sadly appropriate. The second is, yes, Chris carefully enunciated. Today, unfortunately, I'm talking about crises, plural. That's fun. It's we'll get into that. What we're navigating today, from the bad beginning to the end, looking specifically at how some of these crises generated and the roots of them. As we see the kind of month that we've had in healthcare in Alberta, some of these things all start to blur together, given the magnifying and amplifying effects of the pandemic and the pressures that have been put onto our healthcare system in particular. It feels like the extent of this challenge is somehow newer and more present than it has been before, but it has very deep and long and twisty roots. And in Alberta, some of those go back years and decades. So what I'm going to try to do here in 20 minutes is untangle some of those decades of bad decision making and to really emphasize that that's what we're seeing today is the results, not of inevitable global forces, an unpredictable virus that has somehow wiped out our most resilient and enduring national public service, which happened. However, this is the result of political choices. And those choices were not inevitable. There are and were and still can be alternatives to those choices. I was reading an article just in the last couple of days from Naomi Klein around her new book. She used this term that I think is going to unfortunately be really relevant for all of us going forward, which is around a series or cluster of crises, and she's calling a polycrisis. So we're thinking here today about this multi-headed hydra in healthcare, where each of these challenges seems like a piece to itself, but are actually reinforcing and amplifying and magnifying the others. But while some of these challenges are certainly taking place in other provinces or in the national or international context, what's really important here for Alberta are the local and provincial decision-making and environment that has contributed to those. So out of curiosity, thinking about my emphasis on that word crises, I pulled up a little Google search, Alberta Healthcare Crisis 2023. And I got so many hits that I had to group and summarize all of the headlines just for the past year. The one that kind of made my heart drop, just very recent from the last few weeks, respiratory virus outbreaks surging again in long-term care. And I'm going to focus a little bit in on long-term care and why that speaks so heavily to lessons that we have not learned in policy and politics here. In the last 12 months, we've had the AMA and groups of doctors and physicians continually, this language, sounding the alarm, raising flags, bringing up warnings about these impending crises or crises that are already here, specifically around access to primary care, the number of family medicine practices or clinics that are having to close. This is from the Red Deer Advocate and something that's particularly challenging in central Alberta right now. Coming on the tail of that, a 78% drop in doctors accepting new patients over the last 3 years. The Auditor General's report warning that long-term care is unprepared for the next crisis. I thought we had lots of advice on how to prepare for that, but we're not there yet. This is July of this year. May, what happened in May? There was a fundamental opportunity to make different political choices in May, during which 192 doctors in Alberta signed a letter that said there's a huge capacity crisis in our healthcare. Like, we're at a moment we can stop this truck barreling down the highway. Prior to that, again, AUPE warning about healthcare staffing shortages. In March, the focus was on the EMS crisis, and many, government reports and panels providing all sorts of suggestions that perhaps missed the fundamental point around creating better conditions for emergency medical services workers and paramedics to be able to do their jobs and provide care in a rapidly changing situation. January to September of 2023, I put an end date on the labs crisis as though somehow the recent decision to reabsorb Dynalife lab services will end that crisis. It has not. We'll talk a little bit more about that today, but I had to give it dates. November and December of last year, this time last year, pediatric hospitals, ERs across this province were close to collapse. The wait times compounded by RSV, influenza, and continuing COVID-19 infections in children, and something around a lack of basic medical supplies like children's Tylenol in this province. And the ongoing crisis around drugs toxicity, which continues to impact so many aspects of these other challenges here. It also disheartens me to be able to reuse slides. It goes to show how often the same problems keep coming up again and again. This is a quote that I came across last year from author Daniel Dawes on the political determinants of health, and I urge you to read the book to understand some of these concepts. The point about making political decisions that have life or death consequences, and I think that in the past few years that's never hit home quite so closely as it has for us here amidst the pandemic and these other challenges. But thinking a little bit further back in which some of these upstream decisions were made and who they were made for, who they were made to benefit, and who has experienced the fallout from those decisions. I don't know, do we remember this guy? This Ralph Klein riding the Trojan horse, our former director of Parkland, Trevor Harrison, who wrote the seminal book on the Trojan horse. And so it won't come as a surprise to anyone in this room. These things aren't new decisions. And advocates for public health care in Alberta often feel like it's Groundhog Day. I think, that our politicians and our policymakers are rolling out these same rhetoric and these same tactics, but just in an updated packaging. So when we start to think back to the roots of some of these challenging situations that I'm going to go through, I think very pithily by quote here, that it's actually about the retreat of the government from certain aspects of healthcare that creates opportunities for entrepreneurs and for profit making, and for sort of leaving that space open to the kind of negative changes that we're seeing. And Lorian points out as well, though, there's also an opposite shift here happening regarding tightening control and government intervention in healthcare in perhaps the wrong ways. Who's this guy? Does anybody know a guy called Lyle Oberg? He's come back. We're so glad he's come back. And this was a fabulous quote I found from him when I was researching for the report Blurred Lines on access fees for private medical clinics, which Lorian alluded to. Those are back as well. I think this thoroughly epitomized former Minister Oberg's approach to healthcare as an opportunity. Because healthcare is going to be there. People are going to get ill. And for himself personally, that has often presented itself as an opportunity for investment. Considering his new role, maybe we all might want to look a little bit more into his history with private hospitals. And also this guy. So again, thinking about the truth by technicality, and again, this builds so much on what Lorian has laid out for us here about accessibility, which I love how Kenny misspelled that there, a publicly funded healthcare system. Publicly funded, and the guarantees that were offered are very, very technical reading of those lines. And we've seen the extent to which Premier Smith, one of her first actions coming into the premiership was to reaffirm this badly worded guarantee. because it in no way constrains those plans that have now been set in motion, as we've seen. To be able to say, unfortunately, as we saw in the election, the framing of this sort of existential threat to our public health care as one about credit cards, unfortunately, it is not representative of the whole truth of the experience. Despite things like we've seen with the access fees, the NDP has issued private members bill 201, to try to legislate and prohibit those access fees. But primarily, the real challenge and the existential threat for our healthcare system isn't about having to pull out your credit card yet. And I think in some ways that has missed a really important part of the debate, because it leaves open some of these other changes that are not getting the kind of pushback that they would. What that leaves us with following the May 2023 election is a healthcare environment over the last few years. While in absolute terms, the healthcare budget has increased, the explicit mandate set by the finance minister from budget 2023 onwards, and that this is bolstered by legislation, is that public services spending must be kept at or below population plus inflation. So there will be no way to increase those budget lines to account for previous underfunding, new challenges, global crises like a pandemic, or increased demand or increased need. So there's very, very little flexibility there. And that comes on top of approximately $10 billion that has been cut from across Alberta's public services since the UCP took government in 2019. And we all remember the sort of symbolic moments of creating that hostile political environment between healthcare professionals, between their representatives, their unions, their regulatory bodies, the shredding of the physicians' contracts, and that very confrontational approach that this government and its predecessor have taken, particularly against healthcare professionals. And as we've seen again and again, that Lorian alluded to, so many policies being brought forward that are the opposite of evidence-based. I don't even have a word for that. They're just unscientific. It's like based on a feeling, like it's kind of a vibe. I feel like we should do these things. And again, enshrining of avenues of corporatization into our healthcare system, which are designed to be irreversible. So thinking about those contracts for things like lab services, for things like elective surgical procedures, all of these contracts are designed to be ironclad. They're designed to have massive penalties for canceling them, and to really integrate these new contracted services into the other fabric of healthcare to make it very difficult to cancel or reverse. So that's kind of where we're at, and what has been the result of these things. Rural hospital bed closures, which have continued. These numbers are unfortunately from last summer. That continues to be very much the case, if not worse. I think Chris might have updated ones on those. So across many of the small communities in our province facing a real difficulty accessing those services. Doctors disappearing. Very difficult to get official numbers on how many physicians are leaving the province. And there's a lot of pushback saying, well, there's still more doctors registered in Alberta this year than there were last year. How many are keeping their practices open and taking new patients? So again, what we're seeing, anecdotal evidence, my wee little word map at the top, or collected by researcher Kim Seaver on Alberta Worker last year, were people who had lost their family physician in all of those communities across the province. And again, a record number of Albertans last month looking for a family physician, up to 650,000. That's where we are. We'll talk a little bit about what that means in terms of seniors care and in terms of labs and in terms of contracted surgeries. Part of this is around framing how and why these bad decisions were made and what the repercussions have been. It's really difficult to talk about seniors care without emphasizing the absolute exhaustion of researchers and advocates and residents and their families for saying the same thing over and over again for decades. At the height of the pandemic, there was the Royal Society of Canada commissioned a report by some of the top experts on seniors care globally who happened to be in Canada to talk about what needed to happen to reimagine seniors' care. And in the preamble, they cited over 150 reports over the last 2 decades that have essentially repeated the same calls for concern and the same proposed policy solutions that have just gone unheeded. So thinking about that atmosphere in terms of how continuing care, residential care for seniors, it's not for lack of information or a lack of proposed solutions. It's that there's a lack of willingness to put the investment in to make those changes that we know will improve the quality of care and the quality of working conditions for the healthcare providers in those systems. 2020, we conducted a survey of long-term care workers through CUPE Alberta. When we received our responses, our final ones trickled in the first week of March 2020. So these numbers reflect before the pandemic, workers' experiences of understaffing and workload within those long-term care facilities. And 90% said their facility was understaffed at some time. This is the norm, that they were understaffed prior to the pandemic. 75% said they didn't have time during their shifts to complete necessary tasks. That's care tasks, feeding residents, taking them to the washroom, helping residents with hygiene or basic personal tasks, sitting with residents and speaking with them and providing any kind of social or emotional care was so far down the list. It was literally presented on wish lists from our respondents. I wish I could talk with my residents. On the one hand, we saw how devastating those conditions became during the height of the pandemic when COVID was taking its toll through those facilities, including, residents being left unfed, dehydrated, in very dire straits. And all of this puts a huge emotional, physical toll onto long-term care workers. So again, Parkland researchers have extolled this toll and talked about the absolute crucial point in this to improve those working conditions for long-term care, to increase the standard hours of direct care being offered for residents, to bring that in line with the evidence, and to recognize that ownership, delivery, and profit status were directly correlated with those negative health outcomes prior to and during the pandemic. So spell it out here. The for-profit long-term care chains had by far the worst rates for outbreaks, for resident deaths, and for impacts to workers as well. Workers who were less compensated, workers who felt consistently understaffed. And that continues. Talking here, what is the lesson that has not been learned here? Let's ask Sophia. Picture it, Sicily. None of this has changed, particularly in Alberta. The number of slow movements that's been happening in seniors' care has been entirely driven at the federal level in terms of the national care standards. Those have been brought in. However, they're entirely voluntary. There's very, very little enforcement involved in those. They're not legislated. They're not tied to funding. They're a nice suggestion that we improve these things. The new money to improve compensation and reduce precarity for long-term care workers has again all been provided at the federal level. And in Alberta, whatever movement is happening on that is aiming for that minimum level that has been mandated by Ottawa and no further. And in the meantime, working more and more to prop up and fund private for-profit facilities at the expense of public ones. So I'm going to race through some of these. The Alberta Surgical Initiative, the Hostile Hospital, if you have read it. Really to look through, Parkland researcher Andy Longhurst, who's out of Simon Fraser, did a report for us called Failing to Deliver. He dived right into the numbers on this Alberta Surgical Initiative, looking at contracted surgeries. He has recently, only in the last week, also released a report with CCPA and the Ontario Health Coalition, doing a very similar treatment for Ontario. He's also researched the phenomenon of contracted surgical facilities in BC. And guess what? The results are astonishingly consistent, which is that the more resources and money that governments put into propping up private surgical contracted facilities, the fewer resources that get put into the public system. This is not an and. This is not topping up to increase overall surgical volumes. What Andy found specifically in Alberta was that as those contracted surgical volumes increased, the public surgical volumes decreased, leading to a decreased volume overall, at a time when those staffing pressures within the nursing and anesthetists workforce, the ability to get an anesthetist to sit in on any OR has been a continuing problem as well. So all of those resources get pulled into these surgical contracted facilities, particularly in a number of them which are guaranteed volumes. At the moment, the failure to learn from these past failures. So everyone can pull up our report from many years ago on the Health Resources Centre in Calgary, which eventually went bankrupt, despite being paid more per surgery than any surgeries were offered on AHS. As Lorian's pointed out, all of these myths about efficiency and cost savings of these particular contracted procedures. A great resource, if you can pick it up, comes from Barrer and Evans et al., Lies, Damned Lies, and Healthcare Zombies. The idea that these same justifications keep getting pulled out, and they're still not true, but we're sure going to hang our entire healthcare budget on these myths. Talking a little bit how all of these contribute to increasing the crisis. When you have these staffing shortages, reduced access to primary care, delayed treatment for patients, that contributes to increased demand on EMS and ERs, increased demand for acute care, increased wait times, fewer resources being put in, and delayed surgeries. The answer isn't to contract out surgeries, it's to focus on the working conditions and the preventative measures at the top of that cycle. There we go. There you go. It should be common sense. Paul Kershaw really emphasized that as well, in his talk yesterday about prevention. And there are so many points of prevention within these cycles. So again, this came just last week from Ontario. Shock of all shocks, the Doug Ford government is paying these for-profit clinics more per surgery than the OHIP covered surgeries. It's blatant in FOIP documents. The response to this revelation and Dr. Longhurst's report was some people just aren't ready for innovation. That came from the Ontario Health Minister. They're just not ready for the kind of innovation we're bringing in here. I might have to skip through lab services except to say, look here, the chronology of chaos. We're talking about chaos, thy name is lab services. This lovely photo I got here is a literal car crash at Dyna Life. Went through the front wall a few years ago. Like if that wasn't foreshadowing, the huge lesson that I'm gonna pull the thread through on these is the inability to recognize how these successive disruptions and these policy 180s and like lab is public, lab is private, we're going to fragment, we're going to have two entities doing the same lab work, we're going to reproduce that lab, but we're still going to have gaps in it, we're going to continue to split the laboratory services workforce and underpay them. All of these things, they're not individual failings, they compound each other so that each time it becomes more and more difficult for that system and the workers who make that system work to continue adapt and keep that train on the rails. This was my timeline talking about all of the changes that have happened with lab services, and I missed the most recent ones. So just picturing what that roller coaster looks like, and why then is that lesson somehow being applied to creating more fragmentation, more systemic disruption and reorganization in the most vital aspects of our healthcare system. So thinking about how this particular government has not learned the lessons of creating political hostility in our healthcare system, of promoting ideology over evidence, and of thinking very, very short term in terms of their immediate political gain, rather than looking at the long-term evidence and thinking, how do we create sustainable healthcare services And we only can do that by improving working conditions, addressing those root causes around staffing and access and equity. And that is absolutely not what's happening here. There's some wise words from a very, very learned healthcare advocate up there who may be in the room. And as we know, we always come back to Nome. This is a standard playbook, and we're just seeing it being run through again and again and again. Unfortunately, the ways in which it's getting handed to private capital can change the way that they look. It's not just the credit card. I won't have to go in too much into the penultimate peril, the next crises, because thankfully Lorian has talked an awful lot about this. To summarize, all of these lessons that we could have seen even at the point of near breaking during the pandemic, from long-term care and from labs and from those failed surgical contracts, there's no evidence to support any of these changes. There is no plan to address staffing, which is the very, very, very foundation of making a sustainable healthcare service. Those costs are not going to frontline services. They're going to pay the 6 executives who left AHS this week their severance packages. Also, 6 executives left, 8 were hired. The disruption and the fragmentation also contributes to instability, and without that kind of consultation, going back to the workers, there's no political buy-in, there's no support, because they have to work amidst this chaos, and they're saying, you're not listening. Over and over and over again, as a researcher coming into any of these, talking to paramedics, talking to lab workers, talking to nurses, what we hear over and over again is this government is not listening to what we need. That leads to the complete wreck. A final thought, this is from Nate Pike, who's done a lot of political commentary and analysis here in Alberta. He's also a healthcare worker. And I think this was so poignant to hear, right? The number of people I've spoken to in the last few days in reference to the chaos that Lorian's outlined so succinctly. The people who work in healthcare and who are actively exploring exit strategies. This only contributes to that vicious cycle where our best and brightest, our doctors, our nurses, our lab techs, our paramedics are going to seek a better environment in which to work and better conditions that are based on science and best practice of care. He says the UCP have no idea what they've done. I suspect they might, and they might need to look at history as well. Thank you.
Lorian, going back to your original org chart, there's no box for public health. What happened to public health? I mean, not just health emergencies. Public health is supposed to be there all the time. It would be just way too much to hope for some kind of reflection on determinants of health, even upstream from public health.
It would have been nice if the box was called primary care and prevention or something to at least nod to that. The government's intended direction for public health is really that they're going to do emergencies, and then the day-to-day of public health will continue to be the medical officers of health, but of course with the threat that any time the government might swoop in and reverse their decisions, or that there may be pressures to consider alternative perspectives or what have you. I think it's going to be difficult to recruit qualified people to a chief medical officer of health role, medical officer of health roles in this province, given that public health doesn't have a role in that overall picture, and where it does fit in, I think is going to be a lot of government intervention.
A little callback to Courtney Howard's talk yesterday, in talking about what is the greatest public health challenge facing us for the future. I don't know that there's going to be any political will to recognize the health implications of climate change, for example, or to further recognize, the drugs toxicity crisis as a public health crisis, and to lean on that expertise. That's clearly been siloed off into other less independent spaces.
I do work in healthcare. I've been working in health for many years. In particular, my interest has been in public health. In the SARS crisis, post-SARS, we had the Naylor report that was released. And the purpose of that report really was to strengthen public health throughout Canada. The national collaborating centers were developed and positioned across the country. And I believe that they assisted in creating some strength in the public health system. Post-COVID, I've not heard whether there is going to be something similar, but Alberta has taken a particular stance on, I would say, dismantling what we have, because what we have, public health actually goes across various components of our healthcare system. Is this something that the federal government needs to step in and take some leadership on, or is it purely a reaction that's going to happen province by province? I think this is really important to consider, given the situation in Alberta.
Post-SARS, the Naylor report, which looked at Ontario but also took a federal approach to public health, and then within Ontario, there was an inquiry report by Justice. I think both of those were very useful in pointing out some of the issues. Some of the recommendations were implemented, others were not. So, for example, this whole discussion of what should the independence of the Chief Medical Officer of Health be was in those reports. I think that post-COVID, there does need to be inquiries both federally and provincially, because of course both had very different roles in managing the pandemic, and I think that provinces need to be doing inquiries, taking stock of how well their public health system worked, where it failed, and that's quite different than the report that we got. So the report that we got is, well, it starts by saying I'm only looking at public health governance, and it was chaired by someone that was, of course, paid to arguably tell the government what it wanted to say. It started by saying, well, so this is only about public health governance, but then it had a final chapter that was just a wide array of strange recommendations for the healthcare system, including private finance and all sorts of other things. And that's not what we want. We want a traditional inquiry chaired by a judge or other independent expert who can interview witnesses and come out with recommendations that are truly independent. That's what we need. We won't get that in Alberta, I don't think. Will we get that in other provinces? And some of those recommendations we can try and hold the government's feet to the fire on? That would be my hope. I think that's the most ambitious version, or the most optimistic version of what we might expect.
This is aimed at more Rebecca, because you had talked about long-term care. Currently, right now, my understanding is the UCP is looking at actually selling off the last few publicly run long-term cares to private. What if we actually restructured it the opposite? Took over all long-term care, took that 30 to 40% corporate profit, used it for care of patients, allowed the long-term carers to actually manage patients and not have to send them into the hospital each and every time to develop a urinary tract infection and pneumonia, manage their care so they're not falling and breaking hips. We would free up so many beds in the public system. We wouldn't have EMS transporting patients continually on a basis back and forth. So look at just doing this entirely, remove all of the private systems from long-term care and make it entirely public.
I have no notes to that system. Surprisingly, one of the approaches that was proposed by the Ontario NDP in their previous, their most recent election campaign, transitioned approach to basically publicizing all long-term care, and they had a costed platform with that, which would be amazing, right? You're not wrong in identifying the way in which we can build on that evidence, which overwhelmingly shows that publicly delivered seniors' care has far greater positive medical outcomes and avoids so many of those pitfalls that you point to. And that goes back decades prior to the pandemic as well. The difficulty, again, that we're always coming back to is, on the one hand, from center of the road governments who will point to the cost. So there were opportunities at the federal level to push harder at some of these things prior to the development of the national standards of care. There were proposals from private members to increase the wages of all long-term care workers to the level of public workers, and all of these sorts of things to help unionize all of them, and all of these proposals. And it always flounders in the liberal world, it flounders on the upfront cost. We're going to have to pay $13 billion to do that, even though it's going to save us $130 billion over the next 10 years, right? And we see that again and again. On the conservative side, it's also recognizing where those interests are, which is fundamentally vested in the private capital that is embedded in our residential long-term care, which essentially being used as real estate holdings. And again, Andrew Longhurst's work on that in BC is eye-opening. So thinking about how do we disentangle some of those vested interests and to push hard on what the evidence shows will provide the best care for our seniors. And it looks like what you outlined, so thank you.
Listening to this presentation, I was thinking what we heard from Stephanie Ross about the upticks of strikes and everything else with the unions. She didn't mention that there was a wildcat strike during COVID with the healthcare workers here. So I'm just wondering, with these bad ideas being presented by Daniel Smith, what are your thoughts on strikes, wildcat or otherwise, being as a way to kind of push back against what we're witnessing with these crises and what is inevitably to come with these restructuring and all that?
Our director at Parkland, Dr. Jason Foster, has actually done a lot of work here, an upcoming report looking at how successive government legislation has really eroded the striking ability for many of our public services unions here in Alberta. On the one hand, there's, I think, a lot of trepidation from healthcare workers. We saw it as well with teachers. There was a huge push from below to encourage teachers to strike over the implementation of the flawed curriculum and things like that. There's a hesitation there saying we don't feel that we have protections around that. However, a really, really informative example might be to look to what's happening in the United Kingdom, where over the last year and a half, there have been rolling strikes across nurses, EMS, junior doctors, across the system, which have caused huge amounts of disruption. I mentioned last year, at one point they were training the armed forces to drive ambulances. And on the one hand, you're saying, well, huge disruption. There are risks that come with that, but it absolutely has fundamentally changed the negotiating game with the government at Westminster. They have to take account of that, and they have the public on side. So it's worth considering.
Can we give one more round of applause to our...